Welcome to Uber School's comprehensive USMLE Step 1 Pathology Study Guide, focusing on musculoskeletal pathology. I'm Pete, and joining me today is my esteemed colleague,
Crash here, ready to dive into the world of bones, joints, and muscles. And let me tell you, this is going to be one heck of a ride.
That's right, Crash. We're about to embark on a journey through the intricate landscape of musculoskeletal pathology. Our goal? To ensure every single student who listens to this passes their USMLE Step 1 with flying colors.
Absolutely, Pete. We're not just aiming for a pass here, we're shooting for the stars. So buckle up, future docs, because we're about to drop some serious knowledge bombs.
Let's kick things off with bone tumors, shall we? These are crucial for the USMLE Step 1, and understanding them can make or break your score.
You got it, Pete. First up on our bone tumor hit list is osteosarcoma. This bad boy is the most common primary malignant bone tumor, and it's got a thing for adolescents.
That's right, Crash. Osteosarcoma typically affects teens and young adults, with a predilection for the metaphyseal regions of long bones. The knee area is a hotspot, think distal femur and proximal tibia.
And don't forget the proximal humerus, Pete. Now, when it comes to imaging, osteosarcoma's got a signature look. What's that look, Pete?
You're talking about the classic sunburst appearance on X-ray, right? It's caused by the radial growth of tumor spicules perpendicular to the bone's long axis. And let's not forget Codman's triangle, that periosteal reaction forming a triangular elevation of periosteum.
Spot on, Pete. Now here's a USMLE style question for our listeners. A 15-year-old boy presents with knee pain and swelling. X-ray shows a sunburst appearance in the distal femur with Codman's triangle. What's the most likely diagnosis?
Well, given what we've just discussed, the answer is clearly osteosarcoma. The age, location, and classic radiographic findings all point to this diagnosis.
Bingo! Now let's talk treatment. These tumors are aggressive, so we're looking at a combination of surgery and chemotherapy. Limb-sparing surgery is often possible these days, but sometimes amputation is necessary.
Excellent point, Crash. And it's worth mentioning that osteosarcoma has a tendency to metastasize to the lungs, so chest imaging is crucial in the workup.
Speaking of metastasis, did I ever tell you about Marcus Cooper? This guy once diagnosed a metastatic osteosarcoma just by looking at a patient's shadow. He said the shadow had a sunburst quality to it.
Crash, I'm pretty sure that's not possible. Let's stick to evidence-based medicine here. Now moving on to our next bone tumor, Ewing sarcoma. This one's part of the small, round, blue cell tumor family.
Right you are, Pete. Ewing sarcoma is a nasty customer that typically affects children and young adults. What's its calling card?
Its hallmark is the translocation T1122, Q24, Q12, which results in the EWSFLI1 fusion gene. This genetic anomaly is present in about 85% of cases and is crucial for diagnosis.
Exactly. And don't forget the clinical presentation. These kids often come in with fever, pain, and sometimes a palpable mass. It's like their body is sending up flares saying, "Hey, something's wrong here."
Good point, Crash. And let's not forget the elevated erythrocyte sedimentation rate, ESR, that often accompanies Ewing sarcoma. Now, on imaging, what are we looking for?
On X-ray, we're looking for the classic onion skin appearance due to periosteal reaction. And on MRI, we might see the characteristic moth-eaten pattern of bone destruction.
Excellent. Now, here's another USMLE style question. A 12-year-old girl presents with fever, bone pain, and a palpable mass in her pelvis. Biopsy reveals small, round blue cells. What cytogenetic study would be most helpful in confirming the diagnosis?
Ooh, I know this one. We're looking for that T1122 translocation. That's the smoking gun for Ewing sarcoma.
Exactly right, Crash. Now let's shift gears to benign bone tumors. The most common one is osteochondroma. What can you tell us about this?
Osteochondroma, the friendly giant of bone tumors. These are cartilage-capped bony projections that typically occur in adolescence. They're like bony tree branches growing out of the metaphysis of long bones.
Nice analogy, Crash. It's important to note that osteochondromas are developmental lesions rather than true neoplasms. They're thought to arise from displaced growth plate cartilage.
Right you are, Pete. And here's a key point for our USMLE warriors. Osteochondromas stop growing when skeletal maturity is reached. If it keeps growing after that, it's time to worry about malignant transformation.
Excellent point, Crash. The risk of malignant transformation is low, about 1%, but it's something to keep in mind. Now, what about the imaging characteristics?
On X-ray, we're looking for that classic cauliflower-like exostosis. It's continuous with the underlying bone cortex and medullary cavity. MR, I can show us the all-important cartilage cap.
Perfect. Now, here's another USMLE style question. A 15-year-old boy presents with a painless bony protrusion on his distal femur. X-ray shows a pedunculated bony growth continuous with the cortex and medullary cavity. What's the most likely diagnosis?
That's a textbook description of an osteochondroma, Pete. The age, location, and radiographic findings all fit perfectly.
Spot on, Crash. Now let's talk about another important bone tumor, giant cell tumor of bone. What's the key feature of this one?
The giant cell tumor, or GCT as we like to call it in the biz. This bad boy is known for being locally aggressive. It typically affects young adults and has a thing for the epiphysis of long bones.
Exactly right, Crash. And it's crucial to remember that while GCT is technically benign, it can be quite aggressive locally and can even metastasize in rare cases.
You got it, Pete. And here's a fun fact for our listeners. GCT has a predilection for the distal femur, proximal tibia, and distal radius. It's like it's got a roadmap of where to cause trouble.
Nice one, Crash. Now, what about the histology? That's always a high-yield area for the USMLE.
Right you are, Pete. Histologically, we're looking at a sea of mononuclear stromal cells with scattered osteoclast-like giant cells. It's like a cellular party, and everyone's invited.
Great description, Crash. And don't forget, these tumors can cause significant bone destruction, leading to pathological fractures. That's often how they present clinically.
Absolutely, Pete. Now, here's another USMLE-style question for our listeners. A 25-year-old woman presents with wrist pain and swelling. X-ray shows an expansile lytic lesion in the distal radius extending to the articular surface. What's the most likely diagnosis?
Well, given the age of the patient, the location of the lesion, and its radiographic appearance, we're most likely dealing with a giant cell tumor of bone.
Bingo, Pete, you're on fire today. Now let's talk treatment. What's the go-to approach for these tumors?
Treatment typically involves curettage and bone grafting. In more aggressive cases, wide excision might be necessary. And in recent years, denosumab has shown promise as a medical treatment option.
Excellent point about denosumab, Pete. It's a monoclonal antibody that inhibits rank ligand, which is crucial for osteoclast function. It can be used to shrink the tumor before surgery or in cases where surgery isn't feasible.
Spot on, Crash. Now let's move on to our final bone tumor topic, metastatic bone tumors. These are actually the most common bone malignancies in adults.
You got it, Pete. When it comes to metastatic bone tumors, we've got a greatest hits list of primary sites. Care to run through them?
Absolutely, Crash. The most common primary sites for bone metastases are breast, prostate, lung, thyroid, and kidney. I remember it with the mnemonic BPLKT, breast, prostate, lung, kidney, thyroid.
Love that mnemonic, Pete. It's like a secret code for bone metastases. Now, what about the radiographic appearance? That's always a hot topic on the USMLE.
Great point, Crash. Bone metastases can be osteolytic, osteoblastic, or mixed. For example, breast cancer typically causes osteolytic lesions, while prostate cancer often leads to osteoblastic lesions.
Right you are, Pete. And let's not forget about the moth-eaten appearance that osteolytic metastases can create on X-ray. It's like the bone is being eaten away from the inside out.
Excellent visual, Crash. Now, here's another USMLE-style question. A 65-year-old man with a history of prostate cancer presents with new onset back pain. What imaging finding would you most likely expect to see on his spine X-ray?
Ooh, I got this one, Pete. Given the history of prostate cancer, we'd expect to see osteoblastic lesions. These would appear as areas of increased density or sclerotic lesions on the X-ray.
Spot on, Crash. Now let's talk about the clinical implications of bone metastases. They can cause significant morbidity, including pain, pathological fractures, and spinal cord compression.
Absolutely, Pete. And don't forget about hypercalcemia. It's a common complication of osteolytic metastases and can lead to all sorts of problems if not caught early.
Excellent point, Crash. Treatment for bone metastases is often palliative, focusing on pain control and preventing skeletal-related events. This can include bisphosphonates, radiation therapy, and sometimes surgery.
And let's not forget about radium 223, Pete. It's a game changer for metastatic prostate cancer to the bones. It's like sending a tiny army of radiation-emitting soldiers directly to the bone metastases.
Great addition, Crash. Now, as we wrap up our discussion on bone tumors, what would you say are the key takeaways for our USMLE warriors?
Well, Pete, I'd say the big ones are know your classic presentations and imaging findings for osteosarcoma and Ewing sarcoma. Understand the benign but potentially troublesome nature of osteochondromas. Be familiar with the locally aggressive behavior of giant cell tumors, and always keep metastatic disease on your differential for adult patients with bone lesions.
Excellent summary, Crash. And remember, folks, when it comes to bone tumors, location and age of the patient are key clues to the diagnosis. Now, shall we move on to our next topic, arthritis?
Absolutely, Pete. Let's dive into the world of creaky joints as inflamed synovium. Arthritis is a major player in musculoskeletal pathology, and it's crucial for the USMLE Step 1.
Couldn't agree more, Crash. Let's start with the heavy hitter osteoarthritis. What can you tell us about this common condition?
Osteoarthritis, the wear and tear arthritis that's the bane of many an aging joint. It's a degenerative joint disease that primarily affects the articular cartilage and subchondral bone.
Excellent start, Crash. And what are the key risk factors we need to keep in mind for the USMLE?
Great question, Pete. The big risk factors for osteoarthritis are age, it's more common in older adults, obesity, extra weight means extra stress on the joints, and previous joint trauma or injury. Genetics can play a role too.
Spot on, Crash. Now let's dive into the pathophysiology. What's happening at the cellular level in osteoarthritis?
Well, Pete, it's like a demolition derby in the joint. The articular cartilage starts to break down, and the chondrocytes can't keep up with repairs. This leads to the release of inflammatory mediators and matrix-degrading enzymes, further damaging the cartilage.
Great analogy, Crash. And don't forget about the subchondral bone. As the cartilage breaks down, the bone underneath starts to remodel, forming osteophytes or bone spurs.
Absolutely, Pete. Those osteophytes are like the joint's misguided attempt to stabilize itself. Unfortunately, they often end up causing more pain and limiting joint movement.
Excellent point, Crash. Now, let's talk about the clinical presentation. What are the classic symptoms of osteoarthritis?
The hallmark of osteoarthritis is pain that worsens with activity and improves with rest. Patients often describe morning stiffness, but it typically lasts less than 30 minutes. They might also complain of joint crepitus, that lovely crunching sound, when they move the affected joint.
Great description, Crash. And what about the physical exam findings?
On exam, you might find bony enlargement of the affected joints, especially in the hands where Heberden's nodes at the DIP joints and Bouchard's nodes at the PIP joints can form. There might also be limited range of motion and pain with movement.
Excellent, Crash. Now here's a USMLE style question for our listeners. A 65-year-old woman presents with chronic knee pain that worsens with activity and improves with rest. X-ray shows joint space narrowing, subchondral sclerosis, and osteophyte formation. What's the most likely diagnosis?
That's a classic presentation of osteoarthritis, Pete. The age, symptoms, and radiographic findings all point to this diagnosis.
Spot on, Crash. Now let's talk about treatment. What are the main approaches to managing osteoarthritis?
Treatment for osteoarthritis is primarily aimed at symptom management and improving function. Non-pharmacological approaches include weight loss, if the patient is overweight, exercise, and physical therapy. Pharmacologically, we often start with acetaminophen for pain relief and may progress to NSAIDs if needed.
Great summary, Crash. And for more severe cases, intra-articular corticosteroid injections can provide short-term relief. In end-stage disease, joint replacement surgery might be considered.
Absolutely, Pete. And let's not forget about the importance of patient education. Understanding the disease and learning how to protect their joints can make a big difference for these patients.
Excellent point, Crash. Now let's move on to our next type of arthritis, rheumatoid arthritis. This is a very different beast from osteoarthritis, isn't it?
You bet, Pete. Rheumatoid arthritis is like the rebel of the arthritis world. It's an autoimmune disease that causes symmetric polyarthritis, typically affecting the small joints of the hands and feet.
Great start, Crash. Can you walk us through the pathophysiology of rheumatoid arthritis?
Absolutely, Pete. In rheumatoid arthritis, the immune system goes rogue and starts attacking the synovium. This leads to inflammation and thickening of the synovial membrane, forming what's called pannus. This pannus invades and destroys the articular cartilage and underlying bone.
Excellent explanation, Crash. And what about the autoantibodies associated with rheumatoid arthritis? Those are always high yield for the USMLE.
The autoantibodies, the smoking guns of RA. The classic ones are rheumatoid factor, RF, and anti-citrullinated protein antibodies, ACPA, also known as anti-CCP antibodies. These are crucial for diagnosis and can even appear years before clinical symptoms.
Spot on, Crash. Now, let's talk about the clinical presentation. What are the key features that set rheumatoid arthritis apart from osteoarthritis?
Great question, Pete. Unlike osteoarthritis, rheumatoid arthritis typically presents with symmetric polyarthritis, often starting in the small joints of the hands and feet. Morning stiffness is a hallmark symptom, and it typically lasts more than an hour.
Excellent, Crash. And what about extra-articular manifestations? Those are always important to remember for the USMLE.
Absolutely, Pete. Rheumatoid arthritis is a systemic disease, so it can affect multiple organ systems. Some key extra-articular manifestations include rheumatoid nodules, vasculitis, interstitial lung disease, and ocular involvement like scleritis.
Great summary, Crash. Now here's another USMLE-style question for our listeners. A 45-year-old woman presents with symmetric pain and swelling in her wrists and MCP joints, along with morning stiffness lasting 2 hours. What laboratory test would be most helpful in confirming the diagnosis?
I got this one, Pete. Given the classic presentation of rheumatoid arthritis, we'd want to test for rheumatoid factor, RF, and anti-CCP antibodies. These are the most specific markers for RA.
Excellent answer, Crash. Now let's talk about treatment. How do we approach managing rheumatoid arthritis?
Treatment for RA has come a long way, Pete. The goal is to achieve remission or low disease activity. We start with disease-modifying anti-rheumatic drugs, DMARDs, like methotrexate as soon as possible. For more severe cases, we might use biologic agents like TNF inhibitors.
Great summary, Crash. And don't forget about the importance of symptomatic treatment with NSAIDs and low-dose corticosteroids, especially during flares.
Absolutely, Pete. And let's not overlook the non-pharmacological approaches like physical therapy and occupational therapy. These can be crucial for maintaining joint function and quality of life.
Excellent point, Crash. Now, as we wrap up our discussion on rheumatoid arthritis, what would you say are the key points for our USMLE warriors to remember?
Well, Pete, I'd say the big ones are, remember the symmetric polyarthritis typically affecting small joints, the importance of RF and anti-CCP antibodies in diagnosis, the various extra-articular manifestations, and the treatment approach focusing on early use of DMARDs.
Fantastic summary, Crash. Now, shall we move on to our next type of arthritis, septic arthritis?
Absolutely, Pete. Septic arthritis is like the emergency room of the arthritis world. It's acute, it's serious, and it needs immediate attention.
Great analogy, Crash. Can you walk us through the basics of septic arthritis?
Sure thing, Pete. Septic arthritis is a bacterial infection of the joint space. It's typically monoarticular, meaning it affects one joint, and it's a medical emergency because it can rapidly destroy the joint if not treated promptly.
Excellent start, Crash. Now, what are the most common pathogens we need to keep in mind for the USMLE?
Great question, Pete. The most common culprit in adults is Staphylococcus aureus. But we can't forget about Neisseria gonorrhoeae, especially in young, sexually active adults. In kids, we need to think about Streptococcus species and Klebsiella canae too.
Spot on, Crash. And what about the risk factors for septic arthritis?
The risk factors, it's like a who's who of joint vulnerability. We're talking about pre-existing joint disease like rheumatoid arthritis, recent joint surgery or injection, immunosuppression, IV drug use, and underlying bacteremia.
Excellent, Crash. Now, let's talk about the clinical presentation. What are the key features that should make us suspect septic arthritis?
Well, Pete, septic arthritis typically presents with acute onset of severe joint pain, swelling, warmth, and limited range of motion. The patient often has fever and appears quite ill. It's like the joint is sending out an SOS signal.
Great description, Crash. And what about diagnosis? How do we confirm our suspicion of septic arthritis?
Diagnosis is all about that joint fluid, Pete. We need to perform an arthrocentesis and analyze the synovial fluid. In septic arthritis, we typically see a high white blood cell count, greater than 50,000 per microliter, low glucose, and high protein in the synovial fluid. And of course, we need to culture that fluid to identify the culprit.
Excellent summary, Crash. Now here's another USMLE style question for our listeners. A 25-year-old man presents with acute onset of severe right knee pain, swelling, and fever. Joint aspiration reveals cloudy fluid with a WBC count of 75,000 per microliter. What's the most appropriate next step in management?
Ooh, I got this one, Pete. Given the high suspicion for septic arthritis, we need to start empiric intravenous antibiotics immediately. We can't wait for culture results. Time is joint tissue.
Absolute right, Crash. And speaking of treatment, can you walk us through the management of septic arthritis?
Sure thing, Pete. Treatment of septic arthritis is a two-pronged approach. First, we need to start empiric IV antibiotics immediately. We typically use a broad-spectrum regimen that covers Staph aureus and other likely pathogens. Second, we need to drain the joint either through repeated needle aspiration or surgical drainage.
Excellent summary, Crash. And it's important to note that once we have culture results, we can narrow our antibiotic coverage based on the specific pathogen and its sensitivities.
Absolutely, Pete. And let's not forget about the importance of supportive care minus pain management, joint immobilization during the acute phase, and then early mobilization once the infection is under control.
Great points, Crash. Now, as we wrap up our discussion on septic arthritis, what would you say are the key takeaways for our USMLE warriors?
Well, Pete, I'd say the big ones are, remember the acute onset of severe joint pain and systemic symptoms, the importance of prompt joint aspiration for diagnosis, and the need for immediate treatment with antibiotics and joint drainage. And always keep in mind that septic arthritis is a medical emergency.
Fantastic summary, Crash. Now, shall we move on to our next topic, crystal-induced arthropathies?
Absolutely, Pete. Let's dive into the sparkling world of gout and pseudo-out. These crystal-induced arthropathies are like the gemstones of the arthritis world, beautiful under the microscope, but oh so painful in the joint.
Great analogy, Crash. Let's start with gout. Can you give us an overview of this condition?
Sure thing, Pete. Gout is a type of inflammatory arthritis caused by the deposition of monosodium urate crystals in the joints. It's like the joint gets ambushed by tiny, needle-sharp crystals.
Excellent start, Crash. Now, what are the risk factors for gout that our USMLE warriors need to remember?
The risk factors, it's like a recipe for joint trouble. We're talking about hyperuricemia, that's the big one. Obesity, high purine diet, think red meat and seafood, alcohol consumption, especially beers, and certain medications like diuretics.
Great list, Crash. And don't forget about genetic factors. Some people are just more prone to developing gout.
Absolutely, Pete. It's like they won the uric acid lottery, but it's definitely not a prize you want.
Indeed, Crash. Now, let's talk about the clinical presentation of gout. What are the classic features?
Well, Pete, gout typically presents as an acute monoarthritis, often affecting the first metatarsophalangeal joint, the infamous podagra. The affected joint becomes red, swollen, warm, and exquisitely tender. It's like the joint is throwing a tantrum.
Great description, Crash. And what about the timing of gout attacks? That's always a high-yield point for the USMLE.
Absolutely, Pete. Gout attacks often occur at night or in the early morning hours. It's like the crystals are nocturnal party crashers. The pain typically reaches its peak within 12 to 24 hours and can last for days to weeks if untreated.
Excellent, Crash. Now let's talk about diagnosis. How do we confirm that we're dealing with gout?
Diagnosis is all about those crystals, Pete. The gold standard is identifying needle-shaped, negatively birefringent urate crystals in the synovial fluid under polarized light microscopy. It's like finding tiny, shimmering needles in a haystack.
Great analogy, Crash. And what about serum uric acid levels? How useful are they in diagnosing gout?
Serum uric acid. It's a tricky customer, Pete. While hyperuricemia is a risk factor for gout, serum uric acid levels can actually be normal or even low during an acute attack. It's like the uric acid is playing hide and seek.
Excellent point, Crash. Now here's another USMLE style question for our listeners. A 50-year-old man presents with sudden onset of severe pain in his right big toe. The joint is red, swollen, and tender. Synovial fluid analysis reveals needle-shaped crystals that are negatively birefringent under polarized light microscopy. What's the most likely diagnosis?
Oh, that's a classic case of gout, Pete. The location, sudden onset, and those telltale negatively birefringent crystals all point to gout.
Spot on, Crash. Now, let's talk about treatment. How do we approach managing gout?
Treatment for gout is like a 3-act play, Pete. Act 1 is managing the acute attack. We typically use NSAIDs, colchicine, or corticosteroids to quell the inflammation. Act 2 is prophylaxis to prevent future attacks, often with low-dose colchicine or NSAIDs. And Act 3 is long-term management to lower uric acid levels, typically with drugs like allopurinol or febuxostat.
Excellent summary, Crash. And don't forget about lifestyle modifications, things like weight loss, limiting alcohol and purine-rich foods, and staying well hydrated can all help prevent future attacks.
Absolutely, Pete. It's like giving your joints a lifestyle makeover.
Great point, Crash. Now let's shift gears to pseudo-out. How does this compare to gout?
Pseudo-out, the great imitator. Also known as calcium pyrophosphate deposition disease, CPPD. Pseudo-out is caused by the deposition of calcium pyrophosphate crystals in the joints. It's like gout's mischievous cousin.
Excellent introduction, Crash. What are the key differences between gout and pseudo-out that our USMLE warriors need to remember?
Great question, Pete. While gout prefers the first MTP joint, pseudo-out has a thing for larger joints, especially the knee. The crystals are different too. In pseudo-out, we're looking for rhomboid-shaped, weakly, positively birefringent crystals. And pseudo-out tends to affect older individuals and can be associated with metabolic conditions like hyperparathyroidism and hemochromatosis.
Excellent summary, Crash. And what about the radiographic findings? Those can be quite distinctive in pseudo-out, right?
Absolutely, Pete. In pseudo-out, we often see chondrocalcinosis on X-rays. That's calcification of the articular cartilage. It's like the joint is trying to turn itself into stone.
Great description, Crash. Now, here's another USMLE style question. A 70-year-old woman presents with acute knee pain and swelling. Synovial fluid analysis reveals rhomboid-shaped crystals that are weakly positively birefringent under polarized light microscopy. X-ray shows chondrocalcinosis. What's the most likely diagnosis?
That's a textbook case of pseudo-out, Pete. The age, joint involved, crystal characteristics, and radiographic findings all point to calcium pyrophosphate deposition disease.
Excellent, Crash. Now let's talk about treatment. How do we manage pseudo-out?
Treatment for pseudo-out is similar to gout in many ways, Pete. For acute attacks, we use NSAIDs, colchicine, or intra-articular corticosteroids. Prophylaxis can be achieved with low-dose colchicine. The tricky part is that, unlike gout, we don't have great options for preventing crystal formation in pseudo-out.
Great summary, Crash. And it's important to remember to look for and treat any underlying metabolic conditions that might be contributing to pseudo-out.
Absolutely, Pete. It's like playing detective. You've got to look for the root cause.
Excellent point, Crash. Now, as we wrap up our discussion on crystal-induced arthropathies, what would you say are the key takeaways for our USMLE warriors?
Well, Pete, I'd say the big ones are, remember the differences in joint predilection between gout and pseudo-out, know your crystal characteristics, needle-shaped and negatively birefringent for gout, rhomboid-shaped and weakly positively birefringent for pseudo-out. And don't forget about the importance of synovial fluid analysis for definitive diagnosis.
Fantastic summary, Crash. Now, shall we move on to our final arthritis topic, ankylosing spondylitis?
Absolutely, Pete. Let's dive into the world of ankylosing spondylitis, the arthritis that's got your back, literally.
Great introduction, Crash. Can you give us an overview of ankylosing spondylitis?
Sure thing, Pete. Ankylosing spondylitis, AS, is a type of inflammatory arthritis that primarily affects the spine and sacroiliac joints. It's like the spine decides to throw a continuous inflammatory party and everyone's invited, including the eyes and sometimes even the heart and lungs.
Excellent description, Crash. Now, what's the key genetic association that our USMLE warriors need to remember for ankylosing spondylitis?
That would be HLA-B27, Pete. It's like the VIP pass to the AS club. Over 90% of patients with AS are positive for HLA-B27, although not everyone with HLA-B27 will develop the disease.
Spot on, Crash. And what about the demographics? Who's most likely to develop ankylosing spondylitis?
Great question, Pete. As typically affects young adults with symptoms often starting in late adolescence or early adulthood. It's more common in males with a male-to-female ratio of about 3-to-1. It's like the disease has a preference for young men.
Excellent, Crash. Now, let's talk about the clinical presentation. What are the classic symptoms of ankylosing spondylitis?
The hallmark of AS is chronic low back pain and stiffness that's worse in the morning or after periods of inactivity. It's like the spine is staging a protest against immobility. Patients often describe improvement with exercise and worsening with rest, the opposite of what we see in mechanical back pain.
Great description, Crash. And what about extra-articular manifestations? Those are always important to remember for the USMLE.
Absolutely, Pete. The extra-articular manifestations of AS are like unwanted party crashers. The most common is acute anterior uveitis, which affects about 40% of patients. We can also see cardiovascular involvement like aortitis and pulmonary involvement like upper lobe fibrosis.
Excellent summary, Crash. Now let's talk about the radiographic findings in ankylosing spondylitis. What are the classic features?
The radiographic findings. They're like the spine's abstract art. Early in the disease, we see erosions and sclerosis of the sacroiliac joints. As the disease progresses, we get the classic bamboo spine appearance on X-ray, where the vertebrae fuse together. It's like the spine is trying to turn itself into a solid rod.
Great description, Crash. And don't forget about syndesmophytes, those bony outgrowths that bridge adjacent vertebrae.
Absolutely, Pete. Those syndesmophytes are like the spine's attempt to build its own bridges.
Indeed, Crash. Now here's another USMLE-style question. A 25-year-old man presents with chronic low back pain and stiffness that improves with exercise. X-ray shows bilateral sacroiliitis, and HLA-B27 is positive. What's the most likely diagnosis?
Oh, that's a classic case of ankylosing spondylitis, Pete. The age, symptoms, radiographic findings, and HLA-B27 positivity all point to AS.
Excellent, Crash. Now, let's talk about treatment. How do we approach managing ankylosing spondylitis?
Treatment for AS is like a multi-pronged attack, Pete. First line is usually NSAIDs for pain and stiffness. Physical therapy and exercise are crucial. We want to keep that spine as flexible as possible. For more severe cases, we might use DMARDs like sulfasalazone, or biologics like TNF inhibitors or Illinois 17 inhibitors.
Great summary, Crash. And it's important to remember that the goals of treatment are to reduce pain and stiffness, maintain spinal flexibility, and prevent complications.
Absolutely, Pete. We're trying to keep that spine from turning into a rigid bamboo stick.
Excellent point, Crash. Now, as we wrap up our discussion on ankylosing spondylitis, what would you say are the key takeaways for our USMLE warriors?
Well, Pete, I'd say the big ones are, remember the association with HLA-B27, the characteristic symptoms of inflammatory back pain, the classic radiographic findings including sacroiliitis and bamboo spine, and the importance of extra-articular manifestations, especially acute anterior uveitis.
Fantastic summary, Crash. And with that, we've covered our major types of arthritis. Shall we move on to our next topic, soft tissue disorders?
Absolutely, Pete. Let's dive into the world of soft tissue disorders. It's like we're moving from the hard, bony world of arthritis to the squishy, tender world of muscles, tendons, and bursae.
Great transition, Crash. Let's start with fibromyalgia. Can you give us an overview of this condition?
Sure thing, Pete. Fibromyalgia is like the great masquerader of the musculoskeletal world. It's a chronic pain syndrome characterized by widespread musculoskeletal pain, fatigue, sleep disturbances, and cognitive issues. It's like the body's pain amplifier is turned up to 11.
Excellent description, Crash. Now, what are the diagnostic criteria for fibromyalgia that our USMLE warriors need to remember?
The diagnostic criteria, it's like a treasure hunt for pain. The current criteria focus on widespread pain index, WPI, and symptom severity scale, SSS. We're looking for a WPI is greater than or equal to 7, and SSS is greater than or equal to 5, or WPI 4 to 6, and SSS is greater than or equal to 9, and the symptoms should have been present at a similar level for at least 3 months.
Great summary, Crash. And what about the old criteria with tender points? Are those still relevant?
Good question, Pete. While the tender point exam isn't required for diagnosis anymore, it's still good to know. We used to look for pain in at least 11 out of 18 specific tender points when pressure was applied. It's like a connect-the-dots game, but with pain.
Excellent, Crash. Now, let's talk about the pathophysiology of fibromyalgia. What's thought to be going on?
Well, Pete, the exact pathophysiology is still a bit of a mystery, but the current thinking is that it involves central sensitization. It's like the central nervous system's volume control for pain gets stuck on high. There's also evidence of altered neurotransmitter function, particularly involving serotonin, norepinephrine, and substance P.
Great explanation, Crash. And what about risk factors? Who's most likely to develop fibromyalgia?
Fibromyalgia seems to have a thing for the ladies, Pete. It's much more common in women than men. Other risk factors include a family history of fibromyalgia, other rheumatic diseases like lupus or rheumatoid arthritis, and a history of physical or emotional trauma. It's like some people's bodies are primed for pain amplification.
Excellent summary, Crash. Now here's another USMLE style question. A 4-year-old woman presents with a 6-month history of widespread body pain, fatigue, and non-restorative sleep. Physical exam reveals no joint swelling or limitation of motion. What's the most likely diagnosis?
That's a classic presentation of fibromyalgia, Pete. The widespread pain, fatigue, sleep disturbances, and lack of objective findings on exam all point to fibromyalgia.
Spot on, Crash. Now, let's talk about treatment. How do we approach managing fibromyalgia?
Treatment for fibromyalgia is like a 3-ring circus, Pete. In the first ring, we have pharmacological treatments like duloxetine, milnacipran, or pregabalin. In the second ring, we have non-pharmacological approaches like exercise, cognitive behavioral therapy, and sleep hygiene. And in the third ring, we have complementary therapies like acupuncture or mindfulness meditation.
Great analogy, Crash. And it's important to remember that a multimodal approach is often most effective.
Absolutely, Pete. We're trying to attack this pain monster from all angles.
Excellent point, Crash. Now, as we wrap up our discussion on fibromyalgia, what would you say are the key takeaways for our USMLE warriors?
Well, Pete, I'd say the big ones are, remember the diagnostic criteria focusing on widespread pain and symptom severity, understand the concept of central sensitization, know the common associated symptoms like fatigue and cognitive issues, and remember that treatment is multimodal, including both pharmacological and non-pharmacological approaches.
Fantastic summary, Crash. Now, shall we move on to our next soft tissue disorder, bursitis?
Absolutely, Pete. Let's dive into the world of bursitis, where tiny fluid-filled sacs decide to throw inflammatory parties.
Great introduction, Crash. Can you give us an overview of what bursitis is?
Sure thing, Pete. Bursitis is inflammation of a bursa, which is a small fluid-filled sac that acts as a cushion between bones, tendons, and muscles. It's like the body's own little shock absorbers deciding to go on strike.
Excellent description, Crash. Now, what are some common locations where bursitis occurs? Those are always high yield for the USMLE.
The hotspots for bursitis. It's like a tour of the body's pressure points. Common locations include the shoulder, subacromial bursitis, elbow, olecranon bursitis, hip, trochanteric bursitis, knee, prepatellar bursitis, and heel, retrocalcaneal bursitis. Each one has its own nickname, like student's elbow for olecranon bursitis or housemaid's knee for prepatellar bursitis.
Great list, Crash. And what about the causes of bursitis? What should our USMLE warriors keep in mind?
Bursitis is like a multi-factor party, Pete. The guest list includes repetitive motion or pressure, like kneeling a lot for prepatellar bursitis, trauma, a direct blow can irritate a bursa, infection, especially in superficial bursae, crystal deposition, think gout or pseudogout, and systemic diseases like rheumatoid arthritis.
Excellent summary, Crash. Now, let's talk about the clinical presentation. How does bursitis typically present?
Bursitis is like a localized pain party, Pete. Patients typically present with pain, swelling, and tenderness over the affected bursa. The pain often worsens with movement or pressure. If it's septic bursitis, you might see signs of infection like redness, warmth, and systemic symptoms.
Great description, Crash. And how do we diagnose bursitis?
Diagnosis is often clinical, Pete. It's based on the history, physical exam, and location of symptoms. Imaging like ultrasound or MRI can be helpful to confirm the diagnosis or rule out other conditions. If we suspect septic bursitis, we might need to aspirate the bursa and send the fluid for analysis and culture. It's like detective work for the bursa.
Excellent, Crash. Now here's another USMLE-style question. A 45-year-old carpenter presents with pain and swelling over his right elbow. The area is tender to palpation but not warm or erythematous. He reports frequently leaning on his elbows while working. What's the most likely diagnosis?
Oh, that's a classic case of olecranon bursitis, Pete. The location, occupation, and symptoms all point to this diagnosis. It's like his elbow's shock absorber has had enough of the carpentry life.
Spot on, Crash. Now let's talk about treatment. How do we approach managing bursitis?
Treatment for bursitis is like a step-by-step dance, Pete. First step is rest and protection of the affected area. We want to give that angry bursa a break. Next, we often use ice to reduce inflammation and pain. NSAIDs can be helpful for pain and inflammation too. For more persistent cases, we might consider corticosteroid injections. And of course, if it's septic bursitis, we need antibiotics and possibly surgical drainage.
Great summary, Crash. And don't forget about prevention. Addressing any underlying causes or predisposing factors is crucial.
Absolutely, Pete. We want to stop that bursa from throwing future inflammatory parties.
Excellent point, Crash. Now, as we wrap up our discussion on bursitis, what would you say are the key takeaways for our USMLE warriors?
Well, Pete, I'd say the big ones are, remember the common locations for bursitis, understand the various causes including overuse and infection, know the typical presentation of localized pain and swelling, and remember that treatment usually involves a combination of rest, anti-inflammatory measures, and addressing any underlying causes.
Fantastic summary, Crash. Now, shall we move on to our next soft tissue disorder, tendinitis?
Absolutely, Pete. Let's stretch into the world of tendinitis, where tendons decide they've had enough of this motion business.
Great introduction, Crash. Can you give us an overview of what tendinitis is?
Sure thing, Pete. Tendinitis is inflammation of a tendon, which is the tough, fibrous tissue that connects muscle to bone. It's like the body's puppet strings get angry and inflamed. More recently, the term tendinopathy has been preferred, as it turns out many chronic tendon problems involve degeneration rather than just inflammation.
Excellent explanation, Crash. Now, what are some common locations where tendinitis occurs? Those are always high yield for the USMLE.
Ah, the tendinitis hotspots. It's like a tour of the body's overachiever joints. Common locations include the shoulder, rotator cuff tendinitis, elbow, lateral epicondylitis or tennis elbow, and medial epicondylitis or golfer's elbow, wrist, de Quervain's tenosynovitis, hip, iliotibial band syndrome, knee, patellar tendinitis or jumper's knee, and ankle, Achilles tendinitis. Each one has its own claim to fame.
Great list, Crash. And what about the causes of tendinitis? What should our USMLE warriors keep in mind?
Tendinitis is often a tale of too much, too fast, Pete. The main culprit is usually overused repetitive motions that stress the tendon. But don't forget about other factors like age. Tendons become less flexible as we get older, improper technique in sports or work activities, and certain systemic diseases like rheumatoid arthritis or diabetes. It's like a perfect storm for tendon trouble.
Excellent summary, Crash. Now, let's talk about the clinical presentation. How does tendinitis typically present?
Tendinitis is like a localized pain parade, Pete. Patients typically present with pain and tenderness along the affected tendon. The pain often worsens with movement or stretching of the tendon. There might be some mild swelling, and in chronic cases, you might feel or hear crepitus when the tendon moves. It's like the tendon is crying out, "No more, please!"
Great description, Crash. And how do we diagnose tendinitis?
Diagnosis is often clinical, Pete, based on the history and physical exam. We might use special tests depending on the location, like the Finkelstein test for de Quervain's tendinosynovitis. Imaging can be helpful in some cases. Ultrasound can show tendon thickening or tears, while MRI can give us a detailed look at the tendon and surrounding structures. It's like getting a tendon's eye view of the problem.
Excellent, Crash. Now here's another USMLE style question. A 35-year-old tennis player presents with lateral elbow pain that worsens when grasping objects. The pain is exacerbated by extending the wrist against resistance. What's the most likely diagnosis?
Oh, that's a classic case of lateral epicondylitis, or tennis elbow, Pete. The location, occupation, and symptoms all point to this diagnosis. It's like his elbow is saying, "Game, set, and ouch."
Spot on, Crash. Now, let's talk about treatment. How do we approach managing tendinitis?
Treatment for tendinitis is like a recipe for tendon TLC, Pete. First ingredient is rest. We need to give that angry tendon a break. Next, we often use ice to reduce pain and inflammation. NSAIDs can be helpful too. Physical therapy is crucial. We want to strengthen the muscles and improve flexibility. For more persistent cases, we might consider corticosteroid injections, although we need to be careful with these as they can weaken the tendon if overused. And don't forget about addressing any underlying causes or biomechanical issues.
Great summary, Crash. And what about some of the newer treatments we're seeing for chronic tendinopathies?
The cutting-edge stuff, Pete. We're seeing some interesting results with treatments like platelet-rich plasma, PRP, injections, extracorporeal shockwave therapy, and even needle tenotomy for really stubborn cases. It's like we're bringing out the big guns for these tendon troubles.
Excellent point, Crash. Now, as we wrap up our discussion on tendinitis, what would you say are the key takeaways for our USMLE warriors?
Well, Pete, I'd say the big ones are, remember the common locations for tendinitis, understand that overuse is the main culprit, know the typical presentation of localized pain that worsens with movement, and remember that treatment usually involves a combination of rest, anti-inflammatory measures, physical therapy, and addressing any underlying causes or biomechanical issues.
Fantastic summary, Crash. Now, shall we move on to our next soft tissue disorder, carpal tunnel syndrome?
Absolutely, Pete. Let's tunnel our way into the world of carpal tunnel syndrome, where the median nerve decides it's tired of being squeezed.
Great introduction, Crash. Can you give us an overview of what carpal tunnel syndrome is?
Sure thing, Pete. Carpal tunnel syndrome, CTS, is a condition where the median nerve gets compressed as it travels through the carpal tunnel in the wrist. It's like the nerve is trying to squeeze through a too-tight subway tunnel during rush hour.
Excellent analogy, Crash. Now, what are the risk factors for carpal tunnel syndrome? Those are always high yield for the USMLE.
The CTS risk factor roll call. It's quite a list, Pete. We've got repetitive hand motions, like typing or using vibrating tools, obesity, pregnancy, rheumatoid arthritis, diabetes, hypothyroidism, and acromegaly. It's like a who's who of wrist woes. And don't forget, it's more common in women and typically occurs in middle-aged to older adults.
Great list, Crash. And what about the pathophysiology? What's actually happening in carpal tunnel syndrome?
Well, Pete, it's all about pressure in the carpal tunnel. Anything that increases the volume of the contents of the tunnel or decreases the size of the tunnel can compress the median nerve. This compression leads to ischemia of the nerve, causing the symptoms. It's like the nerve is being strangled by its own neighborhood.
Excellent explanation, Crash. Now let's talk about the clinical presentation. How does carpal tunnel syndrome typically present?
CTS has a classic presentation, Pete. Patients typically complain of numbness, tingling, and pain in the distribution of the median nerve. That's the thumb, index, middle, and half of the ring finger. It often wakes people up at night, and they might shake out their hands to relieve symptoms. It's like their hand is throwing its own midnight rave party.
Great description, Crash. And what about physical exam findings? What should our USMLE warriors be looking for?
On exam, we've got a few tricks up our sleeve, Pete. There's the Tinel sign, where tapping over the median nerve at the wrist causes tingling in the fingers. Then there's the Phelan's test, where flexing the wrist for 60 seconds reproduces symptoms. In more advanced cases, you might see the NAR muscle atrophy. It's like a game of find the compressed nerve.
Excellent, Crash. Now, how do we confirm the diagnosis of carpal tunnel syndrome?
While the diagnosis is often clinical, Pete, nerve conduction studies are the gold standard. They can show slowing of conduction across the carpal tunnel. Electromyography, EMG, can also be helpful, especially in ruling out other conditions. It's like we're eavesdropping on the nerve's communications.
Great explanation, Crash. Now here's another USMLE-style question. A 45-year-old secretary presents with numbness and tingling in her thumb, index, and middle fingers that worsens at night. Physical exam reveals a positive Tinel sign. What's the most appropriate next step in management?
Ooh, I got this one, Pete. Given the classic presentation of carpal tunnel syndrome, the first step would be conservative management. This typically includes wrist splinting, especially at night, and addressing any modifiable risk factors. It's like we're giving the median nerve a little vacation home to rest in.
Spot on, Crash. Now, let's talk more about treatment. What are our options for managing carpal tunnel syndrome?
Treatment for CTS is like a ladder, Pete. We start at the bottom with conservative measures like wrist splinting, ergonomic modifications, and addressing any underlying conditions. If that doesn't work, we might move up to NSAIDs or corticosteroid injections. Physical therapy can be helpful too. For severe or persistent cases, we climb to the top of the ladder with surgical decompression, the carpal tunnel release. It's like we're staging a jailbreak for the median nerve.
Excellent summary, Crash. And what about prognosis? What can patients expect after treatment?
Prognosis is generally good, Pete, especially if we catch it early. Many patients improve with conservative management alone. For those who need surgery, most experience significant improvement, although it may take several months for full recovery. It's like the nerve is learning to enjoy its newfound freedom.
Great point, Crash. Now, as we wrap up our discussion on carpal tunnel syndrome, what would you say are the key takeaways for our USMLE warriors?
Well, Pete, I'd say the big ones are: remember the classic presentation of numbness and tingling in the median nerve distribution. Know your physical exam tests like Tinel's and Phelan's. Understand that nerve conduction studies are the gold standard for diagnosis. And remember that treatment is typically stepwise, starting with conservative measures and progressing to surgery if needed.
Fantastic summary, Crash. Now, shall we move on to our final soft tissue disorder, Dupuytren's contracture?
Absolutely, Pete. Let's get a grip on Dupuytren's contracture, where the palm decides it's time for some unwanted remodeling.
Great introduction, Crash. Can you give us an overview of what Dupuytren's contracture is?
Sure thing, Pete. Dupuytren's contracture is a fibroproliferative disorder affecting the palmar fascia. It causes thickening and shortening of fibrous tissue in the palm, leading to finger contractures. It's like the hand is trying to permanently form a claw.
Excellent description, Crash. Now, what about the epidemiology and risk factors? Those are always high yield for the USMLE.
The Dupuytren's demographics. It's quite a specific crowd, Pete. It's most common in older males of Northern European descent. Risk factors include family history, there's a strong genetic component, manual labor, smoking, alcohol use, and diabetes. Some call it the Viking disease due to its prevalence in Scandinavian populations. It's like these folks won a genetic lottery they didn't want to enter.
Great summary, Crash. And what about the pathophysiology? What's actually happening in Dupuytren's contracture?
Well, Pete, it's all about the myofibroblasts gone wild. These cells proliferate and produce excessive collagen, forming nodules and cords in the palmar fascia. Over time, these cords contract, pulling the fingers into flexion. It's like the palm is staging a very slow, very stubborn rebellion against finger extension.
Excellent explanation, Crash. Now let's talk about the clinical presentation. How does Dupuytren's contracture typically present?
Dupuytren's has a classic progression, Pete. It often starts with a painless nodule in the palm, usually at the base of the ring or little finger. Over time, a cord develops, extending into the finger. As the cord contracts, it leads to progressive flexion contracture of the affected finger. Patients often notice they can't lay their hand flat on a table, the tabletop test. It's like their hand is forever stuck in a perpetual high five.
Great description, Crash. And which fingers are most commonly affected?
The ring and little fingers are the usual suspects, Pete. They're like the troublemakers of the hand in Dupuytren's. The middle finger can be involved too, but the index finger and thumb are usually spared. It's like the disease has a preference for the ulnar side of the hand.
Excellent, Crash. Now, here's another USMLE style question. A 60-year-old man of Scandinavian descent presents with inability to fully extend his right ring finger. On examination, you notice a thickened cord in his palm extending to the affected finger. What's the most likely diagnosis?
Oh, that's a textbook case of Dupuytren's contracture, Pete. The age, ethnicity, affected finger, and presence of a palmar cord all point to this diagnosis. It's like his hand is auditioning for a Viking remake of The Claw.
Spot on, Crash. Now let's talk about treatment. What are our options for managing Dupuytren's contracture?
Treatment for Dupuytren's is like a battle against the rebellious fascia, Pete. For mild cases, we might just observe. As it progresses, we have a few weapons in our arsenal. There's needle appointerotomy, where we use a needle to perforate and break up the cord. Then there's collagenase injections, which enzymatically disrupt the cord. And for severe cases, we bring out the big guns with surgical fasciectomy. It's like we're staging a coup against the contracture.
Excellent summary, Crash. And what about recurrence? Is that a concern with Dupuytren's?
Absolutely, Pete. Recurrence is the nemesis of Dupuytren's treatment. It can happen regardless of the treatment method, although rates vary. It's like the disease is playing a game of whack-a-mole with us. We knock it down and it pops up again.
Great point, Crash. Now, as we wrap up our discussion on Dupuytren's contracture, what would you say are the key takeaways for our USMLE warriors?
Well, Pete, I'd say the big ones are, remember the classic presentation of painless palmar nodules progressing to cords and finger contractures. Know that it primarily affects the ring and little fingers. Understand the strong genetic component and association with Northern European descent. And remember that treatment options range from observation to various interventional techniques, with recurrence being a common challenge.
Fantastic summary, Crash. And with that, we've covered our major soft tissue disorders. Shall we move on to our final section, muscle diseases?
Absolutely, Pete. Let's flex our way into the world of muscle diseases, where muscles decide they're tired of playing by the rules.
Great transition, Crash. Let's start with Duchenne muscular dystrophy. Can you give us an overview of this condition?
Sure thing, Pete. Duchenne muscular dystrophy, DMD, is like the heavyweight champion of genetic muscle diseases. It's an X-linked recessive disorder caused by mutations in the dystrophin gene. Without dystrophin, muscle fibers are easily damaged and progressively degenerate. It's like the muscles are trying to hold themselves together with duct tape instead of proper scaffolding.
Excellent description, Crash. Now, what about the clinical presentation? How does DMD typically manifest?
DMD has a classic presentation, Pete. It primarily affects young boys, with symptoms usually appearing between ages 2 and 5. These little guys start having trouble with motor skills. They might have difficulty running, jumping, or climbing stairs. They often have the characteristic Gower's sign when getting up from the floor, using their hands to walk up their own legs. It's like their muscles are playing a cruel game of the floor is lava, but they're losing.
Great explanation, Crash. And what about the progression of the disease? What can patients expect?
The progression of DMD is like a tragic marathon, Pete. The weakness starts in the proximal lower limbs and progresses to the upper limbs. Most boys are wheelchair-bound by their early teens. As the disease advances, it affects cardiac and respiratory muscles. Sadly, many patients don't survive past their 20s or 30s due to cardiorespiratory complications. It's like the body's infrastructure is slowly crumbling.
Excellent, though sobering summary, Crash. Now, how do we diagnose DMD?
Diagnosis of DMD is like a detective story, Pete. We start with the clinical presentation and family history. A key clue is elevated serum creatine kinase, CK, levels. These boys often have CK levels 10 to 100 times normal. Genetic testing for mutations in the dystrophin gene is the gold standard. We might also do a muscle biopsy, which shows absence of dystrophin on immunohistochemistry. It's like we're looking for the missing piece in the muscle's puzzle.
Great explanation, Crash. Now here's another USMLE style question. A 4-year-old boy is brought to the pediatrician because his parents notice he has difficulty climbing stairs and often falls while running. On examination, you notice enlarged calf muscles and a positive Gower sign. What's the most appropriate next step in diagnosis?
Ooh, I got this one, Pete. Given the classic presentation suggestive of Duchenne muscular dystrophy, the most appropriate next step would be to check serum creatine kinase, CK, levels. If those are elevated, we'd move on to genetic testing for confirmation. It's like we're following the breadcrumbs to the DMD diagnosis.
Spot on, Crash. Now let's talk about treatment. What are our options for managing DMD?
Treatment for DMD is like fighting a multi-headed hydra, Pete. We need a multidisciplinary approach. Corticosteroids are the mainstay of treatment. They can slow the progression of weakness. Physical therapy is crucial to maintain function and prevent contractures. As the disease progresses, we need to manage cardiac and respiratory complications. There's also exciting research into gene therapy and exon skipping techniques. It's like we're throwing everything in our medical arsenal at this disease.
Excellent summary, Crash. And what about genetic counseling? That's an important aspect, isn't it?
Absolutely, Pete. Genetic counseling is crucial in DMD. Since it's an X-linked recessive disorder, mothers of affected boys are usually carriers. There's a 50% chance of passing the mutation to each child. It's like these families are dealing with a genetic lottery they never wanted to enter.
Great point, Crash. Now, as we wrap up our discussion on Duchenne muscular dystrophy, what would you say are the key takeaways for our USMLE warriors?
Well, Pete, I'd say the big ones are, remember, it's an X-linked recessive disorder affecting the dystrophin gene. Know the classic presentation of progressive proximal muscle weakness starting in early childhood. Understand the importance of elevated CK levels and genetic testing and diagnosis. And remember that treatment is multidisciplinary, with corticosteroids being a mainstay of management.
Fantastic summary, Crash. Now, shall we move on to our next muscle disease, myasthenia gravis?
Absolutely, Pete. Let's dive into myasthenia gravis, where the neuromuscular junction decides it's time for a communication breakdown.
Great introduction, Crash. Can you give us an overview of what myasthenia gravis is?
Sure thing, Pete. Myasthenia gravis, MG, is like a cellular-level game of telephone gone wrong. It's an autoimmune disorder where antibodies attack the acetylcholine receptors at the neuromuscular junction. This leads to rapid fatigue and muscle weakness. It's like the muscles are trying to function with a bad cell phone connection. The signal just isn't getting through.
Excellent analogy, Crash. Now, what about the epidemiology? Who's most likely to develop myasthenia gravis?
The MG demographics. It's got a bit of a split personality, Pete. There are two peak ages of onset. In women, it often starts in the 20s and 30s, while in men, it's more common after age 50. Overall, it's more common in women, but in older age groups, the male-to-female ratio evens out. It's like MG is playing favorites with different age groups.
Great summary, Crash. And what about the clinical presentation? How does myasthenia gravis typically present?
MG has a classic presentation, Pete. The hallmark is fluctuating muscle weakness that worsens with repetitive use and improves with rest. It often starts with ocular symptoms. Ptosis and diplopia are common early signs. As it progresses, it can affect bulbar muscles, causing dysarthria, dysphagia, and limb muscles. A key feature is that the weakness tends to be worse at the end of the day. It's like the muscles are running a marathon they're not prepared for.
Excellent description, Crash. And what about the association with thymoma? That's always a high yield point for the USMLE.
The thymus, the plot thickens, Pete. About 10 to 15% of MG patients have a thymoma, and up to 50% have thymic hyperplasia. It's like the thymus is trying to get in on the autoimmune action. Importantly, all patients with MG should get a chest CT to look for thymoma.
Great point, Gra. Now, how do we diagnose myasthenia gravis?
Diagnosis of MG is like solving a muscle mystery, Pete. We start with the clinical presentation. The edrophonium tensilon test can be helpful. It temporarily improves muscle strength in MG. Serological tests for acetylcholine receptor antibodies are positive in about 85% of patients. For those who are seronegative, we might look for anti-MuSK antibodies. Electromyography, EMG, with repetitive nerve stimulation is also useful. It's like we're eavesdropping on the neuromuscular junction's faulty conversations.
Excellent summary, Crash. Now here's another USMLE style question. A 25-year-old woman presents with fluctuating double vision and drooping eyelids that worsen as the day progresses. What's the most likely diagnosis, and what test would you order to confirm it?
Oh, that's a classic case of myasthenia gravis, Pete. The age, gender, and fluctuating ocular symptoms all point to MG. To confirm the diagnosis, I'd order a serum test for acetylcholine receptor antibodies. It's like we're looking for the smoking gun in this neuromuscular crime scene.
Spot on, Crash. Now, let's talk about treatment. What are our options for managing myasthenia gravis?
Treatment for MG is like a multi-pronged attack on the autoimmune rebellion, Pete. We start with acetylcholinesterase inhibitors like pyridostigmine. They're like reinforcements for the neurotransmitters. For long-term management, we often use immunosuppressants like prednisone, azathioprine, or mycophenolate. Plasmapheresis and intravenous immunoglobulin, IVIG, are used for myasthenic crisis or before surgery. And don't forget about thymectomy. It's recommended for all patients with thymoma and many with generalized MG. It's like we're trying to reset the immune system's faulty programming.
Excellent summary, Crash. And what about myasthenic crisis? That's an important complication to be aware of, isn't it?
Absolutely, Pete. Myasthenic crisis is the nightmare scenario in MG. It involves severe weakness of respiratory muscles, potentially leading to respiratory failure. It's often triggered by infections, surgery, or tapering of immunosuppressants. Treatment involves respiratory support, IVIG or plasmapheresis, and managing the underlying trigger. It's like the ultimate boss battle in the MG game, high stakes and requires quick action.
Great explanation, Crash. Now, as we wrap up our discussion on myasthenia gravis, what would you say are the key takeaways for our USMLE warriors?
Well, Pete, I'd say the big ones are, remember the fluctuating muscle weakness that worsens with use and improves with rest, know the association with thymoma, understand the importance of acetylcholine receptor antibodies in diagnosis, and remember the multifaceted treatment approach, including acetylcholinesterase inhibitors, immunosuppressants, and sometimes thymectomy. And never forget about the potential for myasthenic crisis. That's a true medical emergency.
Fantastic summary, Crash. Now, shall we move on to our next muscle diseases, polymyositis and dermatomyositis?
Absolutely, Pete. Let's flex our way into the world of inflammatory myopathies, where muscles decide to throw their own inflammatory party.
Great introduction, Crash. Can you give us an overview of polymyositis and dermatomyositis?
Sure thing, Pete. Polymyositis, PM, and dermatomyositis, DM, are like the terrible twins of inflammatory myopathies. They're both autoimmune disorders that cause muscle inflammation and weakness. The key difference is that dermatomyositis also involves the skin. It's like PM is throwing a muscle-only party, while DM invited the skin along for the ride.
Excellent analogy, Crash. Now, what about the epidemiology? Who's most likely to develop these conditions?
The PMDM demographics. They've got a bit of a preference, Pete. Both conditions are more common in women than men. They can occur at any age, but they've got two peak incidence periods, one in childhood, primarily DM, and another between ages 40 to 60. It's like these diseases are trying to cover all their bases.
Great summary, Crash. And what about the clinical presentation? How do polymyositis and dermatomyositis typically present?
The presentation of PM and DM is like a tale of two tissues, Pete. Both cause progressive, symmetric proximal muscle weakness. Patients might have trouble climbing stairs or lifting their arms above their heads, but DM has some skin tricks up its sleeve. Classic skin findings in DM include the heliotrope rash, purplish rash on the eyelids, and Gottron's papules, scaly erythematous papules over the knuckles. DM can also cause a shawl sign rash over the shoulders and upper back. It's like DM is trying to accessorize the inflammatory process.
Excellent description, Crash. And what about associated conditions? Those are always high yield for the USMLE?
Ah, the plot thickens, Pete. Both PM and DM can be associated with other autoimmune conditions like lupus or scleroderma. We call this overlap syndrome. But the real kicker is the association with malignancy, especially in adults with DM. It's like these diseases are sometimes the unwelcome opening act for a cancer diagnosis. That's why we always need to think about cancer screening in these patients.
Great point, Crash. Now, how do we diagnose polymyositis and dermatomyositis?
Diagnosis of PM and DM is like assembling a medical puzzle, Pete. We start with the clinical presentation. Lab tests often show elevated muscle enzymes, especially creatine kinase, CK. We might see myositis-specific antibodies in the blood. Electromyography, EMG, can show a myopathic pattern. The gold standard is a muscle biopsy, which shows inflammatory infiltrates. In DM, we might also do a skin biopsy. It's like we're collecting evidence for the great muscle inflammation caper.
Excellent summary, Crash. Now here's another USMLE style question. A 50-year-old woman presents with progressive difficulty climbing stairs and a rash over her knuckles. Lab tests show elevated creatine kinase levels. What's the most likely diagnosis, and what additional workup would you consider?
Oh, that's screaming dermatomyositis, Pete. The proximal muscle weakness, elevated CK, and characteristic rash, likely Gottron's papules, all point to DM. Given her age and the association with malignancy, I definitely consider age-appropriate cancer screening as part of the workup. It's like we're not just treating the DM, but also looking for any sneaky underlying causes.
Spot on, Crash. Now, let's talk about treatment. What are our options for managing polymyositis and dermatomyositis?
Treatment for PM and DM is like launching a full-scale immunosuppressive assault, Pete. We start with high-dose corticosteroids. They're our frontline troops in this inflammatory battle. If that's not enough, we bring in the reinforcements, immunosuppressants like methotrexate, azathioprine, or mycophenolate. For resistant cases, we might use biologics like rituximab. Physical therapy is crucial to maintain muscle strength and function. And for DM, don't forget sun protection for those skin manifestations. It's like we're fighting a war on multiple fronts: muscles, skin, and the overactive immune system.
Excellent summary, Crash. And what about prognosis? What can patients expect?
Prognosis in PM and DM is like a roller coaster, Pete. With proper treatment, many patients improve significantly. However, some can have a more chronic course with periodic flares. The presence of certain antibodies or associated conditions can affect prognosis. And of course, if there's an associated malignancy, that plays a huge role. It's like each patient is on their own unique inflammatory journey.
Great explanation, Crash. Now, as we wrap up our discussion on polymyositis and dermatomyositis, what would you say are the key takeaways for our USMLE warriors?
Well, Pete, I'd say the big ones are: remember the proximal muscle weakness in both conditions, know the characteristic skin findings in dermatomyositis, heliotrope rash, and Gottron's papules, understand the importance of cancer screening, especially in adult-onset DM, and remember the treatment approach focusing on immunosuppression. Oh, and never forget the trusty elevated CK levels. They're like the calling card of these inflammatory troublemakers.
Fantastic summary, Crash. Now, shall we move on to our next muscle disease, rhabdomyolysis?
Absolutely, Pete. Let's dive into rhabdomyolysis, where muscles decide to go out with a bang rather than a whimper.
Great introduction, Crash. Can you give us an overview of what rhabdomyolysis is?
Sure thing, Pete. Rhabdomyolysis is like a muscle's doomsday scenario. It's a condition where damaged skeletal muscle breaks down rapidly, releasing its contents into the bloodstream. It's like the muscle cells are having a fire sale, and everything must go, including stuff that should stay inside, like myoglobin and electrolytes.
Excellent description, Crash. Now, what are some common causes of rhabdomyolysis? Those are always high yield for the USMLE.
Ah, the rhabdo roster. It's quite a list, Pete. We've got trauma, like crush injuries, extreme exercise, heat stroke, and prolonged immobilization. Then there's drugs and toxins. Think statins, alcohol, cocaine. Electrolyte imbalances, especially hypokalemia, can cause it. And don't forget about genetic muscle diseases and infections. It's like a who's who of muscle mayhem.
Great list, Crash. And what about the pathophysiology? What's actually happening in rhabdomyolysis?
Well, Pete, it's all about cellular chaos. When muscle cells are damaged, they lose the ability to regulate calcium influx. This leads to activation of proteases and lipases, which further damage the cell. As the cells break down, they release their contents, including myoglobin, creatine kinase, electrolytes, and other cellular debris, into the bloodstream. It's like each muscle cell is a piñata, and rhabdomyolysis is the stick breaking it open.
Excellent explanation, Crash. Now, let's talk about the clinical presentation. How does rhabdomyolysis typically present?
Rhabdomyolysis has a classic triad, Pete: muscle pain, weakness, and dark urine from myoglobinuria. But here's the catch. This triad is only present in about 10% of cases. Patients might have swollen, tender muscles. They can also have nonspecific symptoms like nausea, fever, and malaise. In severe cases, we worry about complications like acute kidney injury, electrolyte imbalances, and compartment syndrome. It's like the body is dealing with a massive muscle meltdown.
Great description, Crash. And how do we diagnose rhabdomyolysis?
Diagnosis of rhabdomyolysis is all about the labs, Pete. The hallmark is a massively elevated creatine kinase, CK, level. We're talking 5 to 10 times the upper limit of normal and often much higher. Myoglobin in the urine is the culprit behind the cola-colored urine. We also see electrolyte imbalances, hyperkalemia, hyperphosphatemia, and later, hypocalcemia. And of course, we need to monitor kidney function closely. It's like we're reading the aftermath of a cellular disaster in the lab results.
Excellent summary, Crash. Now, here's another USMLE style question. A 25-year-old man presents to the ER with muscle pain and dark urine after an intense CrossFit workout. His serum creatine kinase is 15,000 U/L. What's the most critical complication to monitor for?
Ooh, I got this one, Pete. Given the presentation of rhabdomyolysis, the most critical complication to monitor for is acute kidney injury. The myoglobin released from damaged muscle can be toxic to the kidneys, leading to acute tubular necrosis. It's like the myoglobin is playing demolition Burmy in the nephrons.
Spot on, Crash. Now let's talk about treatment. How do we manage rhabdomyolysis?
Treatment for rhabdomyolysis is like a race against time, Pete. The cornerstone is aggressive IV fluid administration. We're talking about flushing out those kidney-damaging substances. We need to correct electrolyte imbalances, especially hyperkalemia, which can cause cardiac arrhythmias. In severe cases, we might need to consider renal replacement therapy, and of course, we need to address the underlying cause. It's like we're trying to put out a fire while simultaneously rebuilding the house.
Excellent summary, Crash. And what about the use of bicarbonate or mannitol? Those are sometimes mentioned in the treatment of rhabdomyolysis.
The controversial players in the rhabdo game, Pete. Some folks advocate for urine alkalinization with bicarbonate, thinking it might help prevent myoglobin precipitation in the kidney cubules. Mannitol is sometimes used for its potential in flushing out nephrotoxic substances and reducing compartment pressures. But the evidence for these isn't super strong, and they're not routinely recommended. It's like they're the bench players in our rhabdo treatment team. We know they're there, but we're not always sure when to put them in the game.
Great explanation, Crash. Now, as we wrap up our discussion on rhabdomyolysis, what would you say are the key takeaways for our USMLE warriors?
Well, Pete, I'd say the big ones are: remember the diverse causes of rhabdomyolysis, know the classic triad of symptoms, even though it's not always present, understand the importance of massively elevated CK levels in diagnosis, and remember that aggressive IV fluid administration is the mainstay of treatment. And never, ever forget about monitoring for and managing acute kidney injury. That's the big bad wolf in the rhabdo story.
Fantastic summary, Crash. Now, shall we move on to our final muscle disease, fibrodysplasia ossificans progressiva?
Absolutely, Pete. Let's dive into fibrodysplasia ossificans progressiva, where the body decides that being made of flesh is too mainstream and tries to turn itself into stone.
Great introduction, Crash. Can you give us an overview of what fibrodysplasia ossificans progressiva is?
Sure thing, Pete. Fibrodysplasia ossificans progressiva, or FOP for short, is like the body's most extreme makeover gone wrong. It's an ultra-rare genetic disorder where skeletal muscle and other soft tissues gradually turn into bone. It's like the body's 3D printer has gone haywire and is printing bone where it shouldn't.
Excellent description, Crash. Now, what's the genetic basis of FOP? That's always a high-yield point for the USMLE.
Ah, the genetic culprit behind FOP. It's a real troublemaker, Pete. FOP is caused by a mutation in the ACVR1 gene, which encodes for a bone morphogenetic protein, BMP, type 1 receptor. This mutation causes the receptor to be constitutively active, leading to excessive bone formation. It's like the body's bone-forming switch is stuck in the on position.
Great explanation, Crash. And what about the clinical presentation? How does FO typically manifest?
FOP has some telltale signs right from birth, Pete. The classic finding is malformation of the great toes. They're typically short and bent inward. But the real drama starts in early childhood when the heterotopic ossification begins. It often starts in the neck and shoulders and progresses downward. Flare-ups can be triggered by trauma, surgery, or even viral illnesses. These flare-ups cause painful, swollen lesions that eventually turn into bone. It's like watching a person slowly turn into a statue.
Excellent description, Crash. And how does this progressive ossification affect patients?
The effects of FOP are devastating, Pete. As the disease progresses, it leads to severe restriction of movement. Joints become permanently fixed in place. The chest wall can become rigid, leading to breathing difficulties. Even the jaw can become fused, making eating challenging. It's like the body is building its own prison of bone, trapping the person inside.
That's a sobering description, Crash. Now, how do we diagnose FOP?
Diagnosis of FOP is a bit of a double-edged sword, Pete. The characteristic toe malformations and early heterotopic ossification are usually enough for a clinical diagnosis. Genetic testing for the ACVR1 mutation can confirm it. But here's the catch. Doing a biopsy can trigger more bone formation. It's like poking a sleeping bear. You might get your answer, but at what cost? That's why awareness of the clinical features is so crucial.
Excellent point, Crash. Now, here's another USMLE style question. A 2-year-old girl is brought to the pediatrician with a painful, swollen area on her back. She was born with malformed great toes. What's the most likely diagnosis and what precautions should be taken?
Oh, that's screaming fiber dysplasia ossificans progressiva, Pete. The malformed toes and the swollen area, likely the start of heterotopic ossification, are classic for FOP. The key precaution here is to avoid any unnecessary procedures or trauma, no biopsies, no intramuscular injections, and be very careful with any physical examinations. It's like we're dealing with a bone-generating powder keg. Any spark could set it off.
Spot on, Crash. Now let's talk about treatment. What are our options for managing FOP?
Treatment for FOP is like trying to stop a runaway train with your bare hands, Pete. Currently, there's no cure, and treatment is largely supportive. During flare-ups, we use corticosteroids to reduce inflammation. Some docs use bisphosphonates, thinking they might slow the new bone formation. Physical therapy can help maintain mobility, but it needs to be very gentle to avoid triggering flare-ups. There's ongoing research into potential treatments targeting the overactive BMP pathway. It's like we're desperately searching for the brakes on this bone-forming freight train.
Excellent summary, Crash. And what about prognosis? What can patients with FOP expect?
The prognosis for FOP is pretty grim, Pete. As progressively disabling, with most patients wheelchair-bound by their 20s or 30s. The median lifespan is around 40 years, with death often due to cardiorespiratory complications from chest wall rigidity. But there's hope on the horizon with ongoing research. It's like these patients are in a race against time, hoping medical advances can catch up to their condition.
That's a sobering but important point, Crash. Now, as we wrap up our discussion on fiber dysplasia ossificans progressiva, what would you say are the key takeaways for our USMLE warriors?
Well, Pete, I'd say the big ones are, remember the characteristic malformed great toes present at birth. Know that heterotopic ossification typically starts in childhood and progresses throughout life. Understand the ACVR1 gene mutation as the cause, and remember that trauma, including medical procedures, can trigger flare-ups. And never forget, in a patient with suspected FO, biopsy is a big no-no.
Fantastic summary, Crash. And with that, we've covered our major muscle diseases. As we wrap up this Uber School production on musculoskeletal pathology, any final thoughts?
Well, Pete, I'd say we've really flexed our pathology muscles today. From the wear and tear of osteoarthritis to the stone-cold reality of FOP, we've covered a lot of ground. Remember, future docs, the musculoskeletal system is like a complex machine. When it works, it's a beautiful thing, but when it breaks down, it can break down in some pretty fascinating ways. Keep these conditions in mind, always consider the patient's whole picture, and you'll be well on your way to acing that USMLE.
Couldn't have said it better myself, Crash. And remember, listeners, this has been an Uber School production. We're here to help you build the knowledge you need, one step at a time. Until next time, keep studying, stay curious, and remember, in the world of medicine, knowledge is power, and power is the ability to help your future patients. This is Pete, signing off.
And this is Crash, reminding you that whether it's bones, joints, or muscles, understanding the pathology is key to mastering medicine. Keep learning, keep growing, and who knows? Maybe one day you'll be as smart as Marcus Cooper, who once diagnosed a rare case of fibrodysplasia ossificans progressii just by hearing the patient's footsteps. Now that's a level of expertise to aspire to. Crash out!